Good evening and welcome to UPMC Sports Surgery Clinic evening on joint replacement for the hip and knee. I'm Fiona Roach. I'm the general manager here in the Sports Surgery Clinic. For any of you that don't know where we are, we're 10 minutes from Dublin Airport, just off the M1 or off the M50. We're a musculoskeletal hospital, so that means we look after all your joints, replacements, hips, knees, ankles, shoulders. We look after anything to do with musculoskeletal, ACL, sport injuries. We have a state-of-the-art sports medicine department here with a rehabilitative centre, and we have 3 MRIs, over 91 beds and 21 day beds. We've over 30 orthopaedic surgeons that work here and 5 neurosurgeons. Now, we are part of a group called UPMC, and UPMC also have hospitals in Kildare, in Waterford, the Whitfield, and even in Kilkenny. And they have a number of sports medicine centres across the country. There is a tab there if you want to find out more, if that's your area, that you can go into and have a look. You'll also see the tab there for ask a question, so please feel free to ask a question. We will endeavour to get through most of them tonight. There's another question, you see another tab there if you need to make an appointment or you want to download some exercises. Now, we've 2 speakers tonight, so both of those speakers are surgeons here. So first of all will be Mr. Paul Magill, who's one of our hip and knee surgeons, but Paul's going to talk on the hip, and Paul's going to join us live for a Q&A as well after the presentation. Then Mr. Gavin McHugh, who's also a hip and knee surgeon, is going to talk about the partial knee, and Gavin will also join us afterwards. So put any questions up that you have. Okay, so we're going to start with Paul's presentation first on hip arthritis. Thank you.
Good evening. My name is Paul Magill. I'm a consultant orthopaedic surgeon working in UPMC Sports Surgery Clinic in Santry. So I specialise in hip replacements and knee replacements, and this evening I'll be discussing hip arthritis. Pauline was a previous patient of mine, and I went on a journey with Pauline through her hip arthritis journey. So Pauline came to see me early in her diagnosis, and we went through a certain period of managing her problem without surgery. And then it came a point where she could no longer manage. So Pauline decided to go ahead and have hip replacement. She was petrified, but thankfully the procedure went well and she made a great recovery. And for her, this whole journey was so momentous that she decided to celebrate it by renting out her local social club and inviting all of her friends for her new hip party. So it just illustrates nicely that hip arthritis is a journey. And so I suppose that's the theme of this talk. And I'm going to bring you through the different steps of that journey. And I hope by doing so, I will answer the most commonly asked questions that I get in clinic. So starting with, what is hip arthritis and how do I know I have hip arthritis? Is there anything that I can do to stop it or reverse it? Or if I ignore it, am I doing more harm? We can talk about injections, and we can talk about the optimum time to get a hip replacement. We can then talk about the different types and the different nuances of hip replacements. And then finally, recovery. What does recovery entail? Can I play sports? And why am I not recovering at the same speed as the person down the road? So to begin with, what is hip arthritis? Hip arthritis simply means that the shock absorber in your hip is worn away. So this is an X-ray of a patient who has hip arthritis on one side and a healthy hip on the other side. So as we are looking at the screen, on our right-hand side is their healthy hip. So the hip is a ball and socket joint. So that's the ball formed by the femoral head. And that's the socket, which is formed by the acetabulum, which is part of the pelvic bone. And you can see that there's a gap between that ball and socket. That gap is a positive finding. That gap is filled with cartilage, which is your shock absorber. In comparison, as we look at the screen on our left, the patient's right hip, there's the ball, there's the socket, and you can see in this case, there's no gap between the ball and the socket. So this patient's hip cartilage is completely eroded away on their right-hand side. So they have bone touching bone. So that is arthritis. There are lots of causes for arthritis. It could be a childhood injury. It could be a previous infection. It could be a road traffic accident. It could be a disease such as rheumatoid or psoriasis or gout. But more often than not, we label it as osteoarthritis. And osteoarthritis simply means we don't really know what's caused it. and more than likely it's a genetic predisposition. In any case, when it reaches this stage, when it reaches bone touching bone, there's no surgery that I can do to reopen that space. There's no injection that I can put in there to reopen that space. And unfortunately, there's no supplement that you as the patient can take to reopen that space. When the cartilage is gone, it's gone. And the bone-on-bone contact will remain until we do hip replacement. How do you know if you have hip arthritis? So the two most common symptoms are pain and stiffness. But these can be very variable. So if you have any concerns at all, the best thing you can do is see an orthopedic surgeon. And the diagnosis of hip arthritis is usually very quick and easy with an X-ray and an examination. The most common description of pain is groin pain, but it can be thigh, it can be lower back, it could be knee. The most common description of stiffness is the difficulty putting on your socks, but again, it can be very variable. So if you have any concerns, please come and see one of us. The first port of call, once you have a diagnosis of hip arthritis, is to manage it as best you can without surgery. Now, I know a lot of you logging on tonight are probably in the middle of that journey already, and many patients come to see me already halfway along that journey where they have been managing their arthritis for many years without any intervention. The key to managing arthritis is to remain active. So I appreciate this is difficult. How can you remain active if you have a sore hip? But the key is to identify activities that you can tolerate or that your hip can tolerate and do plenty of those. And to identify the activities that you cannot tolerate or that your hip gets really angry with after you do, and to avoid those activities. So for example, if you're a runner, it might be time to cut back on the running and take up more cycling. If you're a farmer and you've got a really busy life, maybe try and cut down your work and get some help on the farm and somebody else to take up the slack a little bit. Simple things like that can get a few more years out of your hip. In conjunction with that is weight loss. Again, easier said than done. I appreciate that. But if you are able to manage weight loss, it will reduce a significant amount of burden from your hip. And thirdly, and lastly, are painkillers. So painkillers are not the answer. They're certainly part of the toolbox, but they're best used intermittently. And it's best if you can stick to the more simple type of painkillers. It's best if you can avoid, if at all possible, morphine-based painkillers, because after a while they don't work. But painkillers are certainly a useful part of the toolbox, especially if they mean you can remain active. If you need to take a painkiller to remain active, to get it out for that big long walk, by all means, take it. It's better to take the painkiller and remain active. Two very common questions I get at this stage are, can I stop it or reverse the process? Unfortunately not. There are a lot of supplements out there like glucosamine, hyaluronic acid, turmeric. All of these things are good and they do no harm. And some people find that they're great. So by all means, you should try them. But unfortunately, there is no evidence. If you look at the data objectively, there's no evidence that they will make any difference to your arthritis in the long term. And probably most importantly, if I ignore it, am I doing more harm? The answer to that is categorically no. I can reassure anybody who has hip arthritis, the best thing you can do is remain active. It does not benefit from rest. Activity is really important because it maintains the muscle bulk around your hip. And if your muscle bulk around your hip is strong, it will act in some way as an external shock absorber, but also if you eventually do go towards hip replacement, the stronger your muscles are going into the operation, the more predictable your positive outcome will be post-operatively. So you are not doing more harm. Find whatever way you can to remain active. There will come a point, however, where there will be a decision whether or not to operate. So because we're using the theme of a journey in this talk, let's bring it back to roads. So I would ask you, which of these three roads would you consider repairing or resurfacing? Certainly, I don't think anybody would argue that the road on the right hand of our screen is in disrepair and needs fixed or repaired. But what about the road on our left? It's a little bit cracked, but it's certainly workable. I guess we could resurface that if it's a very busy road, but if it wasn't a very busy road, we could leave it alone. What about the one in the middle? Well, it's progressed to potholes. Not a very good road, but it's still workable if it wasn't a busy road. Well, the same applies to hips. I think the hip on the right, you can argue there's no hope for that hip. And of course, that patient would definitely benefit from hip replacement. Whereas the one on the left, it's just about bone touching bone and it's only on one side. So you may get a few more years out of this hip yet. Whereas the one in the middle, it's kind of somewhere in between the two. The patient has both hips affected. You can see there's bone touching bone on both hips, but it's certainly not as bad as the one on the right. The problem is, though, that patients are not roads. Clearly, there's more nuance to managing patients than there is to managing roads. So I have patients who come into me with x-rays like the one on the right, but they don't want a hip replacement. They're able to manage their symptoms just fine. Likewise, I have patients who come to me with the x-ray on the left, and their pain is out of control. So the decision to operate is not simply based on x-ray, and it's simply not made by me, but it's a decision that we come to together, and it's largely based on your symptoms. It's important to highlight, obviously, that hip replacement is a big operation. And of course, like every big operation, it carries risks. So hip replacement is a great operation. It's successful in over 90% of people, but if you're one of the unlucky ones, statistics don't matter. So of course, there are risks like nerve injury, dislocation, infection, and it's important that patients know this. And this is an excerpt from my clinical letters. So if you do have a hip replacement under my care, this will be included in the letter which I post to you in preparation for your surgery. So it's important when you're making the decision that you realize this is not just something you should be taking lightly. Hip replacement is a major undertaking. If we do decide in surgery, unfortunately, there are no other options than total hip replacement. Keyhole surgery has no role if there's already established arthritis. Likewise, stem cell therapy has no role if there's already established arthritis. So the only show in town is total hip replacement. Thankfully, that's a great operation. So much so that in 2007, The Lancet, which is one of the most prestigious medical journals, it published a paper on the operation, and the title of the paper was The Operation of the Century, Total Hip Replacement. So it is a fantastic operation. It and cataract surgery are comparable in terms of results. Pretty much every other operation has a much poorer result than those two. Hip replacement was invented by John Charnley as an orthopaedic surgeon from Manchester in England, and this was in the early 60s. And in a lot of ways, things have changed since the 1960s, but in a lot of ways, things haven't changed. The basic concept and the ingredients of a hip replacement are still pretty much the same today. Our materials have improved. We're much more streamlined in the way we do things. But a lot of things are very much the same. One of the biggest changes, I suppose, is in the patients that we treat. In the early 60s, John Charnley would have treated only patients who were in dire need. So this is a video of a lady he treated. This is a video, the same patient, the left and the right. And you can see that this poor lady was struggling to walk. Her hips were so bad that they were contracted in a fixed crossed position. She struggled to get from A to B. And clearly you can see walking very well 6 months later. But this lady would have spent weeks, possibly up to 6 weeks lying in bed, possibly with the broomstick between her legs to keep her hips apart while they healed. So it would have been a very laborious and long recovery, whereas now we're performing hip replacements on people like this. Whilst this is amazing, and whilst it's a validation of Charnley's concepts, it's also a problem because we shouldn't ignore the fact that the primary reason to do hip replacement is to take away pain. And patient expectations nowadays need to be managed much more carefully than they used to be back in the day of Charnley. So clear expectations for the patient are key. So both of these expectations on screen now are not correct. So some patients have an expectation, if I don't have surgery, I'm going to end up in a wheelchair. Well, I would suggest that's not correct. Very few people end up in a wheelchair. I can't remember of the last person I've met who's ended up in a wheelchair because of hip arthritis. Most people are able to maintain some level of mobility, no matter how bad their hip is. On the other end of the spectrum, it's an incorrect expectation to think that you're going to be a brilliant runner. You're going to be running like Usain Bolt after your hip replacement. Of course you're not. So both of these expectations are incorrect. And it's important that that's clear and that's signposted prior to hip replacement. The best thing that I can signpost for any patient going into hip replacement is, if you have a hip replacement, there is an over 90% chance, possibly even as high as 95% chance, that you will no longer have pain in your hip. Everything else is secondary. So can I play sports after my hip replacement? Maybe, maybe not. Even if you can do things like skiing, playing tennis, running marathons, of course, we all know people who've done this after hip replacements. The bigger question is, should they be doing those things? And I would argue they shouldn't. If you're doing these things, you're placing yourself either in a risky position where you could be doing damage to your hip, or you're going to wear out the artificial hip sooner than you should be. So having a hip replacement comes with some sense of responsibility. So if we did hip replacements and only Andy Murray's in the world, our results would not be as positive. After you've made the decision to go for hip replacement, the other factors surrounding hip replacement should be discussed with your surgeon. And that's because the answers to those questions are specific to you, the patient, and specific to the surgeon. So there's lots of things we can discuss. There's a implant shape, there's a type of fixation. Do we use cement or not? There's the materials that we use in the hip replacement. There's the surgical approach. We can put the hip in from the front, or we can put it in from the back. So the front is called the bikini incision. The back is called the posterior approach. And there's reasons why each surgeon chooses that approach, and there's patient factors and surgeon factors for that. There's the articulating surfaces. So that's probably the most important thing to consider. So most hips these days, we use a ceramic ball and a plastic liner. There's the concept of the hip replacement. Is it a total hip replacement or a resurfacing hip replacement? Some surgeons, like myself, advocate for day case surgery. I think there's a lot of positives for that, for the right person. Robotics are advocated by some surgeons. And some surgeons advocate for doing both hips at the same time if both hips are bad enough. But it's difficult to say as a globalized talk the answers to all of these questions. This is something you need to discuss with your surgeon after you've made a decision for surgery. So these shouldn't affect whether you're going for surgery, but they can be teased out with your particular surgeon. Recovery is said to take about 6 weeks, and part of that is true. So this is a graph of data from my own patients. So if you have a hip replacement under my care, I log you onto an app and I invite you to submit your surgical scores, both preoperatively and postoperatively. So you can see the surgical scores preoperatively are poor, and that the scores make a significant improvement. And that improvement is most marked within the first 6 weeks. But you can see that the improvement continues right up to 6 months, 1 year, and beyond. So recovery really does take 1 year. By all means, the first 6 weeks are the most important, and that's when you'll have the most contact with me and the physiotherapist in terms of information. But recovery will continue for up to a year. So it really is a journey. And lastly, you shouldn't compare yourself to others. So we are all different. We all recover at different speeds. So don't worry if you're not off your crutches at 6 weeks. Don't worry if the old man up the street is recovering much quicker than you. And paradoxically, younger people often do recover slower than older people. And that's because probably they've higher muscle mass, so it takes longer to heal. And secondly, expectations are different. So it's dangerous to compare yourself to others. But of course, if you think you have a problem, contact your surgeon. So just to reiterate, hip arthritis is a journey. Like any journey, it has its highs and lows, it has its challenges. Hip replacement is not the pinnacle. Hip replacement is part of that journey, and recovery can take up to a year afterwards. So thank you very much. I'd be happy to take any questions you may have.
Paul, thanks for joining us tonight, and thanks for that talk on the hip. So we have some questions coming in now. So from Margaret, I'm 57, I suffer with severe hip pain. What are your views on the plasma injections? And also the second question is, does cholesterol medication cause joint pain?
Yeah, hi Margaret. Yeah, good questions. I'll deal with the second one first, actually. Do cholesterol medications cause joint pains? They can. They definitely can. It's not common. Everybody in the street is on a cholesterol medication, but not everybody has joint pain. Yeah. But there are definitely incidences where if you're not able to figure out the reason for the pain, if the x-rays don't look too bad and the patient still has pain, sometimes I will stop the cholesterol medications or ask the GP to stop the medications if it's okay to do so. And that in some cases can help the pain. If the x-rays show arthritis, however, it's more than often the arthritis causing the pain. Okay. The other question, the
plasma injection, yeah.
So injections are good in the right person at the right time. Plasma, I believe, is no better than steroid, which is no better than hyaluronic acid, which is no better than stem cells. There are a lot of things you can have injected. If you look at the medical literature, the evidence would suggest that they all work in the same way, and that is they all have an anti-inflammatory effect. So I think they all really pretty much do the same thing. And again, if you look at the literature, they all seem to have the same level of effect. So yeah, I'm happy that some patients get plasma injections, but it has to be for the right patient at the right time. They're very rarely a cure for the problem, but they can temporize things and give you a little bit longer out of your native hip prior to proceeding to surgery.
Lovely, thanks, Paul. Okay, direct anterior minimally invasive surgical approach for hip replacement. Does this procedure give a quicker recovery?
Yeah, so that procedure, the anterior approach, has been in the news recently. I'm aware of that. Anterior approach is not a new approach. It's been used for a very long time. And it really is surgeon preference. It's really what the surgeon has been trained in. So I have experience of doing the anterior approach during my training, but I decided against it. I personally use the posterior approach. Like everything, there are positives and negatives to anything. There's no perfect solution. So I felt that in my hands, the posterior approach gives better results. It doesn't result in any quicker recovery. So personally, I've done a lot of people day case procedures with the posterior approach, and they recover just as quickly as somebody who does the anterior approach. Both are good approaches, both have their positives, both have their negatives, but it would be untrue to think that one results in a quicker recovery.
Thanks, Paul. Right, this is a question from Tom. He says, it seems like every second to third person these days is having a hip or a knee replacement. Does Ireland have a higher rate than other nationalities?
Yeah, I think you're right. There is a lot of people having hip and knee replacements these days. I don't know if Ireland has a higher rate than anywhere else. I don't think so. I have trained abroad, and certainly they're equally busy in New Zealand and Australia, where I have worked as well. So I don't think Ireland has a higher rate than anywhere else. We do have a higher rate of hemochromatosis, so that may be something that we don't fully appreciate, but I don't think so. Why does this happen? Why are so many people having hip and knee replacements? I think it's expectations. Back in the olden days, if your granny or granddad had arthritis, they sat in the corner of the room beside the fire and they didn't expect much. These days, we as a society expect much more from ourselves, and I think we intervene earlier and we're more aggressive. We know that hip replacements and knee replacements work, so we're probably more aggressive in suggesting them for patients.
Thanks, Paul. What's your opinion on a failed hip labral repair and a borderline dysplasic hip, 47-year-old, suffering from chronic pain from sitting especially, which is impossible to avoid in normal life, causing poor quality of life? Is she a candidate for hip replacement? Yes.
Yeah, I guess I can't say for sure without seeing the imaging, but what you have described there are, you're ticking a lot of boxes for why you should have hip replacement. If you've no quality of life, if you can't do the basics in life, hip replacement is an excellent option for taking away pain. As I said in my talk, there's an over 95% chance that hip replacement will take away your pain. So as long as your x-rays or your scans fit with your clinical picture, certainly from your clinical picture, it sounds like you would benefit from a hip replacement. Even though you're young, if you're in that much distress, yeah, you should speak to your surgeon about hip replacement for sure.
Okay, there's some other questions that come in as well. Do you have an opinion on robotic surgery for hip replacement?
So it's similar to the anterior approach. Robotic surgery is increasingly in the news, and it's a similar answer to the anterior approach. It's got positives and negatives. Robotic surgery can be extremely accurate. You can cut 1 degree or 1 millimeter, but that does not always translate into a better clinical outcome. Robotic probably has a role, but I would encourage you to consider your surgeon more than the robot. The best results we see over and over again are surgeons who do a lot of hip replacements or knee replacements. It's the volume which gets good results. If a surgeon is using a robot and only doing 1 or 2 cases, I can guarantee you those results are not going to be as good as somebody who's doing a lot. And I think that's probably the most important factor in choosing your surgeon and choosing your hospital.
Yeah, thanks, Paul. Someone said they've had Perth's disease since they were 7, and they're wondering, was 28 too young for a hip replacement?
Wow, yeah, 28 is very young. Is it too young? No, I have operated on people in their 20s before. I never liked doing it. No surgeon ever enjoys doing a hip replacement in somebody so young. But again, like the previous question, if your life is so miserable, if you're struggling to cope, then of course we can consider it as a last resort. Again, it's hard for me to say for sure without seeing the imaging, but the purpose of hip replacement is to take away pain and restore some quality of life. And that's applicable to any age. We do hip replacements in teenagers if there's absolutely no resort left. It's a big step, but if it's restoring some quality of life, it can be considered.
Yeah. Okay, one more now. Someone's asking about if they've pain outside of their hip, but I think like on the top of the leg, the groin, they mean, would that be indicative that they should get maybe checked just in case they need a hip replacement?
Groin pain is typically hip related, so by all means, it doesn't necessarily mean there's hip arthritis.
Yeah.
It can be lots of things in around the hip joint which give you pain. But by all means, yes, please get it checked out. Come and see us. We can get you examined and scanned. Yeah.
Paul, thanks very much for joining us
pleasure.
tonight. Lovely. Now, Mr. Gavin McHugh is we're going to do his presentation now about the knee, and then Gavin's going to join us for a live question and answers as well. Thank you, Paul.
Thank you.
Good evening, ladies and gentlemen, and thank you very much for joining me this evening for our series of talks from UPMC at the Sports Surgery Clinic. And this evening I'm going to be giving a talk with regard to knee replacements, but from a slightly different angle. And the talk is entitled Getting Away with a Uni. And hopefully, as we go on, I'll be able to explain a lot more. And some of the slides actually have quite a bit of information in them, and I'll only be touching over some of the detail, but it's just so that there is more information there for people who actually want it. And I'll try and, as I say, keep things as simple as I possibly can. So the first question is obviously, what is a uni or unicondylar knee? Or it's often referred to as a partial knee replacement as well. Well, the knee joint, I always say to people, is one big joint. All right. Essentially, the capsule of the knee goes right the way from the top of the bottom to the joint. But within the joint itself, there are 3 separate areas, which sounds very non-technical, but that essentially rub off each other. All right. The first is where the kneecap or patella rubs off the front of the femur. And the second and third then are where you can see the diagram in front, where the femur divides into 2 knuckles, one on the inside, one on the outside. And they essentially rub off the meniscus or cartilage on the inside and the outside, respectively, and a piece of the tibia. So essentially, there are 3 areas within that joint that make contact with each other. And a knee replacement, as we know it, essentially replaces all 3 of those. But we know that there are lots and lots of people who get wear within one of those areas, and either of the 3 areas can be replaced. The most common by far is the one on the inside knuckle, which would be a medial unicondylar knee replacement. And these account for about 90% of the partial knees that I would do. The outside to a lesser extent. And then lastly, certainly for me, would be the patellofemoral or the one at the front. And if you just look, then this is a sort of a classic X-ray, and the 2 views are slightly different. One is just with the knee a little bit more bent, but you can see that on the inside knuckle, there's a bit of narrowing, and with the knee bent a little bit more, the 2 ends of the bone essentially make contact with each other. And that would be what we call isolated medial compartment arthritis within that knee. You can kind of see where, and I would often compare this to the tread on a car tire or something like that there, whereby the wheels aren't balanced and essentially the tire is pretty bald on one side and fine on the outside. All right, that's unfortunately where the analogy kind of ends, because what we do then is we just take off the tire and replace it with a new tire. Whereas if you could imagine if it was possible to retread part of the tire, that's essentially what the idea of what a partial knee would be. And this is then just an X-ray. Then it's actually the opposite side of the knee, so it's not the same patient's knee at all. Just to complicate things, the X-ray to the left is the view from the front. The middle one is the view from the side. And you can see essentially what you do with a partial knee is that you replace a bit of the end of the femur and a bit of the end of the tibia. All right. And as I say, from me, the majority of these are on the inside knuckle, as is shown here. The X-ray on the right is the front view of a total knee replacement for comparison, and you can see there where you essentially replace the whole end of the tibia and the whole end of the femur, and what you have to do in order to do that there is you got to take out the anterior cruciate, and you may or may not take out the posterior cruciate as well, depending on basically the configuration of the knee itself. And every total knee replacement relies on the ligaments on the inside and the outside, whereas a partial knee replacement relies on having everything there. So you maintain your cruciate ligaments as well. And this is one of the big benefits when it comes to the knee, in that it tends to feel and move and behave much more like the native knee, and hence they're a big part of the reason that I'm such a fan of it. All right, in that it is by far the most natural feeling knee that I can give back to someone where possible. Now, so, and just going through, sorry for I think there are very few gory pictures in this here, I hope. All right, talk. The first thing I like to say about partials, all right, is to break the myth that some people often say, oh, they're very difficult to do. And that's something that's just simply not true. Like everything else, it's a technique that just needs to be learned and performed well. But they can be extremely repeatable. And this actually is one person that I had replaced both sides on at the same time, and essentially the cuts of bone that I've taken off were exactly the same. The implants that I put in were exactly the same on both sides, and actually the tourniquet time was exactly the same on both sides, as you can see from the machine. And it just goes to show that you can actually execute the plan really well with a partial knee. And for me, this is, as a surgeon, it's great to have something that is extremely repeatable, that you can do pretty much the exact same thing time and time again. And that's one of the best ways where we give best outcomes for our patients. And so again, there's a lot of detail in this slide. I don't expect you to know it, but it just to explain a little bit, in that partial knee replacements a number of years ago were sort of very much limited, in that there was like under 5% of knee replacements that were performed were partial knees. And these criteria that were described a number of years ago placed very sort of strict conditions on what you could and couldn't do a partial knee on. And since that, the Oxford group, which would be a major users of partial knees, have come. They've revised all these criteria, and essentially up to about 50% of knees in all comers now are potentially suitable for a partial knee, rather than the old sort of from the old criteria, it was about 10% that would be suitable. Now, in saying that, whilst up to half of knees are potentially suitable for partial knees, the uptake of them remains relatively low. And I think that's for a number of reasons. I think there's a lot of fear, there's a lot of sort of ignorance out there about how they can perform. And again, as I say, I just want to go through and sort of bust some of these myths, if that's possible. So the one myth that other surgeons will often say to me is that I just don't see them, as in I don't see patients that are suitable for partial knees. And this is essentially just not true, in that it's like everything, you see what you want to see. And if you're a fan of using a particular operation, you'll see lots of people with it. If you're not, you simply won't. But there are lots and lots of patients out there who are suitable for partial knees, is essentially the now then. If we move on and look at some of the indications for, so the classic indication essentially for a partial knee would be bone on bone wear in that affected compartment, and that's something that we tend to stick with, although there are indications whereby people who present with a pretty nasty tear in their cartilage and have a bit of wear, often the problem with them is that they'll often get worse if you go ahead with keyhole surgery. And certainly there are lots and lots of patients out there who we know that have unfortunately actually almost fallen off a cliff edge in terms of their symptoms get worse after keyhole surgery. Again, there are very sort of definite indications for arthroscopy or keyhole surgery, but we have to sort of remember that sort of middle-aged patients with these what we call degenerative tears in the cartilage, often it's very, very much more sensible to take things a lot slower, and we'll often just try an injection or a couple of injections to try and let things settle down. And one of the big problems with what we do, I suppose, is that everything doesn't always obey the rules, and quite often we'll see patients with nasty tears in the cartilage, quite a bit of wear, and the knee can completely settle down and they can remain symptom-free for potentially years and years. Others with even simpler tears just don't sometimes get better and settle down. And as I say, these are the ones who potentially I would consider going in that little bit earlier with a partial knee. But obviously this would be after several consultations and potentially a trial of a couple of injections before jumping in with something even like a partial knee. Busting a couple more of the sort of the myths with regards to the maximum weight with regards to a partial knee, and the short answer is there isn't one. Now, there's potentially maximum weights issues with regards to going ahead with an anesthetic or going ahead with a spinal. But in terms of the pure load on the knee for a partial knee itself, there isn't actually one. And this initial criteria was a weight of 82 kilos. And this is complete nonsense. This just doesn't exist now. And indeed, it can be a really, really successful operation in patients essentially of all sizes. And there's the post-operative there they were both knees at a separate sitting, actually. And then if we go and we then look at sort of this, believe it or not, this picture on the right is a post-operative picture, and this is actually at 6 weeks following a partial knee replacement, and you can see that the bend is pretty much a complete knee bend, and this is something that you would very, very rarely see with a total knee replacement. Certainly, it would be extremely usual at 6 weeks. And anecdotally, we used to always sort of settle for sort of 90 degrees after a few weeks. But now we'd look to sort of 105, 110 degrees bend in someone after with a total knee replacement at 6 weeks, but certainly not the like of this bend, which is pretty much 150 degrees. And the questions then that you need to sort of ask yourself in terms of getting a knee is that, as you can see there, would you prefer a knee that feels better, functions better, but may not last you as long? We'll just talk about the outcomes in years to come down the line. And would you prefer a knee that has a quicker recovery or one that potentially lasts a bit longer? Would you prefer a knee with less risks but that has a higher failure rate? And I'll often say then, is a total knee replacement a procedure for a patient or the surgeon? And sometimes the answer, I think, honestly, is that it's more of a procedure for the surgeon. And that what I mean by that is that with a partial knee, you have to be prepared to sort of deal with other issues down the line in years to come. And these shouldn't necessarily be looked at failures at all. But the bottom line, as I say, is would you prefer a knee that feels better, moves better, and allows you back to more activities? Now, and this is the problem in that what we do with regards to a consultation, it's unfortunately an awful lot to try and sort of get your head around when it comes to sort of having been seen, having your history taken, your examination completed, looking at any imaging, and then having a discussion on what or where we go from there. And it can take a bit of time, and it is kind of hard to get your head around for all of us, never mind someone who's just hearing about it for the first time. And the problem with that I see it as for informed consent is that, well, we can't assume what we think patients want to know. And some patients love a lot of detail with regards to what they're going to get done. Other people just want it fixed. But we cannot assume that we know what is best for the patient. And those days are essentially gone, whereby it is now a question of going, well, which would you potentially prefer? And if we sort of look at, again, there are lots of numbers on this here, on this graph, but basically these figures are odds ratios for different risks and problems, comparing a partial knee with a full knee. And essentially, a partial knee, if you look at all the risks on the right, a partial knee replacement comes with a lot less risk. So you can see most of those figures are half that there, or 0.5 or less, that sort of number. In fact, death at 30 days, which is thankfully extremely unlikely, is less than a quarter that of a full knee. And all the risks, I sort of summarize them by saying, on average, the risks are a half to a third that of a full knee. Now, the downside then is that you're potentially 1.4 times more likely to have a further operation within the next number of years. So you have to be able to sort of decide whether you want less risk, or do you want a safer, a knee that's going to last longer and longer, right? And the other thing then, the last factor to bring into that there is, well, how does the knee feel and perform? And this OKS is the Oxford Knee Score, and essentially the higher score, the better patients do. And you can see that the risks of having a much better score or more satisfied knee is significantly higher with a partial knee than with a full knee. And what we know from lots and lots and lots of literature is that on average, following a full knee replacement, about 90% of people are happy, which leaves about 10% of people who aren't happy in some shape or form. And that's unfortunately quite a significant number. And the big issue with that, obviously, is that, well, once a knee is replaced, there is in general no going back. There are potentially other things that can be done, but you certainly can't go back and swap it back for the knee that you had prior to surgery. That's for sure. Now, then if we look at a score called a forgotten knee score, and you can see here that, so basically the higher the score, the better. And the forgotten knee score is it does as it says on the tin. It's a questionnaire that assesses how people feel their knee is forgotten for various activities. So it'll ask you things like, getting in and out of a car, downstairs, or with general day-to-day activities, how much awareness you have of that knee. So obviously a higher score, the better. And you can see there the partial scores for a partial knee replacement are significantly better than that of a full or total knee replacement. So yeah, the next myth I would like to bust is that someone saying, well, I don't have a problem, all my total knees do well. And unfortunately, this is just not the case. A total knee, unfortunately, is not an operation for everyone, and it comes with potential problems. So the other alternative procedure when it comes to fixing isolated arthritis within the knee is a procedure called a high tibial osteotomy. And essentially, if you look at the diagram on the right side, it involves cutting the tibia bone opening it up on one side in a wedge shape, and then fixing that with some plates and screws. And the idea is that you offload the worn side and basically take the load away from the worn side and increase it on the non-worn side. And younger patients, indeed patients of multiple ages, this is a procedure that can work well. And this is often sort of reported to be essentially it's an operation that preserves your joint, which it technically does. But one thing that it doesn't necessarily do is result in a more normal feeling joint than that of a partial knee replacement. That's been demonstrated in several studies. Again, if you look at potentially the risks of partial knee replacements compared to the osteotomy group as well, again, there's plenty of evidence to say that the risks are actually lower in the partial knee group, not higher as one would sort of potentially think. And there's more information there for patients who wish. And again, the myth just there is that joint preservation has potentially less complications than something which seems more invasive as in a partial knee. And again, then if we look at how partial knees behave in terms of return to sport, and this is something that is becoming more and more important for us, and certainly something I would hear of more day to day, in that I see lots and lots of patients, some in their 30s, some in their 40s, with well-established arthritis on one side of their knee, but also lots of patients in their 50s, 60s, 70s who are very fit and active and want to remain that way. And obviously it's a much bigger sort of challenge for us as surgeons to be able to get patients back doing all the activities that they want to do. And just purely with regards to an osteotomy, one would sort of intuitively think that you're more likely to get back to sports when you have your old joint. And in fact, that's not necessarily the case at all. And a partial knee replacement is every bit as likely to get people back to sports. Now, it is very important, I suppose, that to a certain extent I put the brakes on there a little bit, in that if people are running marathons, if people are involved in really, really high-end activities, they have to know that any form of either osteotomy, replacement, be that a partial or a full, may not reliably get them back to the level that they wish to. Right? It isn't necessarily the case, but it certainly can't be guaranteed. And ultimately, I suppose any form of replacement or even an osteotomy is an end of the sort of the road procedure, and it's much more to get you back doing your normal day-to-day activities rather than high-end sporting activities as such. Now, if we look then at return to sports for a partial, you can see there that there's plenty of data here that lots of people can get back to. You can see the activities: hiking, cycling, swimming, and even winter sports are quite possible to get back. Now, a lot of these activities, I often say to people that it's much more of a philosophical question rather than a sort of a physical one in terms of can you get back? Well, a lot of the time you can get back to them. The question is do you want to sort of run that risk of something happening? And again, if someone wants to go back skiing, I have certainly no problem with them with a total knee or a partial knee. They potentially can, but they have to realize that there is always a small chance that they could have a fall and run into difficulties. But that can happen either with or without a knee replacement, for sure. Anyway, and year to year we see lots of the results of these. And another myth that it's often out there is that it's harder to actually convert as either an osteotomy or a partial knee replacement down the line to a full knee replacement. That's in patients who, say, several years down the line, say their arthritis has progressed. And in actual fact, I would generally look at a partial knee replacement as something that keeps your options open. If you've taken pretty conservative cuts, and I mean by not taking off an awful lot of bone, then years down the line, patients can generally get away with a standard knee replacement rather than anything complicated. Now, if they have had a full knee replacement early on, then potentially taking that out and converting it to a full knee or a further full knee is essentially a full revision procedure, and that is considerably more difficult. Again, I frequently see patients who've had osteotomies in the past, and it's not an easy total knee replacement down the line. So in many ways, a partial knee is something that keeps options for the future open, not close them. Now, if we look at sort of the results of a partial knee, this data, and again, there's loads and loads of numbers there, but they're just the various different types of partial knee. And essentially, the Physik-Azuk, which is the partial knee replacement I use, if you look at the 15-year results, and this is the UK Joint Registry data, which is for a partial now is out to 15 years, you can see that at 15 years, there's been about an 8% failure rate with these, which is 92% survivorship at 15 years. And this compares to about a failure rate of about 6% for a full knee. So it really only falls very marginally behind a total knee in terms of the potential outcome. And this is obviously with getting to keep 2/3 of your own joint. So as I say, the people often think, oh, it's not going to last. In actual fact, it tends to last very, very well. And this graph on the left side is an interesting one, and this is from the New Zealand registry. And essentially, what they looked at Oxford knee scores, which I mentioned before. So the lower the score, the worse patients are doing. And the number on the side is the chance of getting a revision procedure. And essentially what they showed, so the two bars at the bottom are the partial and full knee. And essentially what they showed in New Zealand was something really quite interesting, in that if you had an unhappy partial knee, you were much, much more likely to get another operation rather than an unhappy full knee. So what basically, to translate that for you, is that, well, if you came back and your partial knee wasn't doing well, a surgeon would on average take it out and put in a full knee. If you came back with an unhappy full knee, you were essentially told, well, listen, there's not much we can do. You've had your knee replaced and that's it. And so that really potentially even skews the data as well, in that it doesn't mean that full knee replacements out there are all happy. It means that the ones that aren't happy are all too often told that there's nothing else that can be done for them. So that's something that you have to sort of bear in mind when it comes to looking at the sort of survivorship on these things as well. And the registry data only essentially looks at how many have been revised. They don't really, there are parts of them that'll look at the scores in terms of how patient satisfaction, but the main emphasis is on survivorship of the implants themselves. And so the last thing I'd like to say there is that the results are simply not true. They can behave really, really well. And so from just a few take-home points, and as I say, there's lots and lots of data to go through there in your own time if you want to look at some of the slides. But for me, when it comes to a partial knee, I would often look at the physiological age of the patient as opposed to their actual chronological age, in that if someone is a really, really good 75-year-old, there is absolutely no reason why they shouldn't have a partial knee replacement. And likewise, if someone is an excellent sort of an active 40-year-old, for me, they can potentially still have a partial knee replacement rather than the alternatives which we spoke about. I think it is extremely important that we maximize injection therapy before going down the route of any significant operation, really. I mentioned to sort of beware the keyhole surgery, and this is something that is still done. It still has a role, but it is important to know that keyhole surgery and lots of these knees that have a bit of wear in them simply won't fix them. I often say to those is with every case that we look at and see, we should be there asking ourselves, can we get away with a unicondylar or partial knee replacement? As I said earlier, in about 50% of cases, the answer is, I think we can. And in terms of where we sort of fix them, we aim to, if your knee is a bit bowed, we'll aim to slightly undercorrect you, as in not leave you completely straight. And this means that we don't increase the load on the outside half of the knee then as well, and thus it should be very rare that any arthritis within the knee will actually progress. This sort of last lady is just one interesting little case to pop up, and it was a 45-year-old who'd previously fractured her tibial plateau. And if you look at the first X-ray, you can see the sort of the pretty big hole in the tibial plateau on the outside. So this is on the opposite side to the vast majority. And the problem there is that, well, and again, it's even more dramatic on the MRI scan, but the problem there is that that's quite a big hole to fill, and a full or total knee replacement in someone who's 45 years of age is anything but ideal. But with this degree of essentially this defect, your options are quite limited. And so what I did there was to go ahead and put in a partial knee on the outside, and you can see that essentially, like, it built the joint right up again. It straightened out her leg, which was pointing essentially the wrong direction beforehand, and yet was quite a small procedure compared to a full knee replacement. And thankfully, she's done very well since. So as I say, there are lots and lots of different options for partial knees. All I say to people is that, well, that they keep an open mind in terms of looking at those options and of what's the right and best option for them. But for me, in approximately up to 50% of cases, a partial knee is an option. So I hope this hasn't confused everyone more than giving them some more information, but it's just to give an overview of what exactly a partial knee is from my point of view, and a lot of the advantages of it that sometimes aren't considered. Thanks very much for your time.
Hi, Gavin. Thank you. Thanks for joining us this evening as well. So the questions are coming in now for knee replacement. So first one is from Marion. How long after a total knee replacement surgery should one expect to be walking without a limp?
It can vary quite a bit, actually. All right. Knees are funny in that the average person finds them pretty difficult to get over. All right.
Yeah.
And yet some people come back and they go, I didn't find it that bad at all. And that 3 or 4 weeks, they're back walking unaided. Now, they're in general the envy of everyone else. All right. So I would say 6 weeks, you're generally walking quite well, but some are still coming in, say, with one crutch at the 6-week mark. All right. Yeah. And it could be another 2, 4, even 6 weeks, and that there. It just varies quite a bit. You know? Yeah. And it depends on what shape you're in beforehand.
I know.
You know, the better you are beforehand, the easier you're in general going to find it.
Okay. Someone's just asking, is knee surgery likely to progress, as hip surgery has done? I think there's been a lot in the news about it recently, to a day surgery case.
Yeah, funny. That's an interesting way of putting it, and perception on things. So the reality is that day case hip and knee surgery has been done for quite a few years now, right across the world. Equally with total knee replacements and partial knee replacements as much as hip replacements. Mm-hmm. Now, the big question is would I like my knee replacement to go home the same day? If I had my knee replaced, would I like to go home the same day? And the answer is absolutely not. Mm-hmm. And I would say that actually to counter that argument, I would say that hip replacement hasn't really progressed at all. It's not. So the most significant progression we've had in hip or knee surgery has probably been the use of tranexamic acid, which is to stop increased bleeding. It is reduced bleeding a lot. So something, such a simple medication that's been around for 100 years has humbled us. All right. Yeah. And sorry, back to the whole idea of the day case. Now, you even with hips, like, I mean, if I had my hip replaced, I'd like to go home after 1, maybe 2 days. That's the sort of time where I think is the sweet spot, where your pain is controlled, you're confident, all right, and you're independently mobile, all right. Now, it's quite possible to go home the same day because quite often you're loaded up on all the local anesthetic that's in the area, all right. But to say, and I don't mean to knock this as the idea, it is a little bit gimmicky in that you're kind of like sent out whilst you're still quite good, and then the rest is up to yourself, right? And obviously, some very young, healthy people can absolutely fly it. But I mean, you'll see anyone after a joint replacement, you'll see their confidence grow day 1, day 2, and even up to day 3. So, I would basically say, listen to people. My advice would be, listen, take the love when you can get it, right? You know, right? It's a big bad world out there, and often, you know, there's no harm whatsoever in a bit of TLC, you know, for that first couple of days.
Yeah, thanks. As question from Larry, 74, extremely active, walks about 10K a day without pain. Had a few arthroscopies though on knee wear and tear from 40 years of running. Has been told that a knee replacement will be required at some stage. Should he get done when he's fit and healthy, or should he wait?
I would say, well, a little bit of both, right?
Yeah.
In that, you get it done when you've a lot to gain by getting it done, right? So we know, we've been through that a knee is of any option or a variety isn't an easy option, right? It's the recovery is hard, and it's often several months, all right? But I mean, if it's causing you day-to-day disability, day-to-day pain that's holding you back from doing your activities you like to do, then it's very reasonable to go ahead and get it done, right? Likewise, what I sometimes don't like to see is someone really quite old just getting sort of, pardon me, put off with another little injection to tide them over for another few months, and then potentially the best window opportunity is running out. But at 74, you're often nowhere near there at all, you know. So it's time, and again, most people, by the time it comes to knee, they're like going, yeah, I'm ready for it, you know.
They know. Yeah. Okay. Ari, someone's right tibia plateau fractured in 3 places in 2016. Has tried Ostinol plus slight relief. Would you recommend Durolane? Trying to delay a partial knee replacement, 66 active.
So absolutely. I mean, Durolane is one brand of hyaluronic acid injections, which we'll frequently use. All right. So sort of they're usually next in line from steroid injections as the sort of stepwise increase in injections that we have. All right. The next sort of would be like PRP or platelet-rich plasma injections as well. And then up from that, which you'll hear some people mention as things like stem cells. And then up from that, which is the I've forgotten the name of the last thing. It'll come to me in a second. Sorry. But anyway, I don't use it. So, and back to the hyaluronic acid. I can't remember that name now. Sorry. For the hyaluronic acid, yeah, I mean, it's simple to try. It's a very low risk profile, and absolutely, if you've had a break that is going to, you know, ultimately end up with something more significant, it's well worth a try. All right, and you simply know if it works for 3 or 4 weeks, it's going to be a waste of time. All right, if it works for several months, all right, and then it's well worthwhile trying. A lady back today brought the injection stuff with her. She got 18 months of complete relief with injections. All right. Now that's, you know, that's towards the other end of the spectrum doing very well, but it still happens quite routinely. So it's very simple to do and worth a try.
Great, thank you. My wife had knee replacement last January and still finds her knee stiff. Sometimes there's a tightness on one side at the back, and one of her knees is bigger than the normal knee. She's 67, very active, has followed all the icing and exercises without fail. Any comments would be appreciated.
So was it January this year?
January this year. So January, still early in a way that, yeah.
Yeah, so even, believe it or not, January last year would still only be just beyond a year and a half, you know?
Yeah.
Right? But at sort of 9-10 months, that's not unusual at all. So we have data to show that knees continue to improve for up to 2 years after surgery, which is really quite remarkable. And quite often, not quite, I could say the odd time you'll see the odd grumbling knee at sort of 6, 9, 12 months even, right? That actually goes on to do pretty well. So I would never say always or never in this game, all right? But it still isn't necessarily run its course as of yet, all right? Replaced knees are sometimes just, not even in terms of swelling, sometimes the tissue around them is just a little sort of thicker and feels a little bit stiffer. And I often think that that females are more likely to sort of perceive a sort of like, or describe a tighter band around the knee. They just seem to be more perceptive in that regard. And do I have definite evidence on that? No, I just see it from time to time.
Yeah.
So I would say it's not unusual, particularly at this stage, and there's still considerable hope.
Lovely. Okay, someone here, they've had 2 knee replacements, one in 2009 at 47, one in 2021 at 59. Excellent recoveries. But how long should they expect them to last given their active walker and hiker?
Yeah, so things like walking and hiking, I would consider normal day-to-day use, all right? And implants like hips and knees are very much designed to take that load, all right? What they're not necessarily designed to take just as well are a lot of like twisting type of sports, all right? So I would say the walk and hiking's all absolutely fine on it, all right? Now, interesting that they put their age for the two as well, in that if you look at, say, UK registry data, which is sort of probably the most similar to Ireland in terms of the spectrum of things that are done, and if you look at the survivorship, say, for a knee replacement, 10 years, 96% of overall knees are going strong at 10 years, right? At 15 years, that might drop down to, I think it's about 91%, and somewhere around 85% at 20 years, right? Now, if you break things down into age that you actually had the first procedure, and they tend to do it in under 55s, that 96% straight off the bat is down to 90% at 10 years, right? So in essence, in younger people, the results tend to be worse, right? So, but all of this is still an odds game, and you'll see plenty of people who had their first knee in at 45, and the thing is still going strong at 30 years, all right? And so very difficult to put an answer to that there. At some stage, one of them will probably cause trouble, all right, and need something doing with again.
Okay, thanks. Tore my meniscus and ACL in the same knee, have had a few injections which have helped. However, there's a small area on the inner side of the cap that's uncomfortable when walking. Walking with a straight leg is easier. Do you know why this is?
So walking with a straight leg will probably not load the patellofemoral joint in the same manner, all right? So you're going to, if it's at the front of the knee, just in on, assuming it's just in onto the patella, it's unlikely to be as sore for that reason. Just you've really no load going through there with a straight leg, whereas as you bend it, the load progressively increases. Quite often what you'll find is, if you think of it, I suppose, full-on arthritis in any area of the knee is a bit like a tarred road where the road is completely worn. What people often have is like a little pothole in the road where there's a little area that's worn. And what could be happening there is that little pothole just manages to engage with another little pothole at a certain angle. So people will sometimes describe it, say, when they're driving a car or something, that they accelerate, that just that angle, let's say 30 degrees or something, is enough to really lift them out of it as such, in terms of, not in terms of acceleration, but in terms of the pain. So it could be something like that as well, as potentially causing it. Yeah. Okay,
last question. This lady had cartilage removed by keyhole from both knees, 17 years ago, one 8 years ago. Now she's in a lot of pain. She's 57. What are her options?
So the options are, well, I mean, depending on the scans, if she had cartilage removed from one side, right, there is a fair chance that these are knees that would be suitable for partial knees, right, which is the first thing that would jump to mind from a surgical point of view. Further keyhole surgery on those knees is not going to be the answer. Pardon me, injection therapy, which we've talked about, is an option in terms of trying to tide things over. At 57, something like an osteotomy, I wouldn't really consider. And potentially, depending on how worn they are, then full knee replacements is going to be if partials aren't suitable, that's really the gambit. And that's the problem, in that we kind of have an all or nothing approach nearly, in that the injections are sort of the least we can do, and then it's a huge step up in terms of partials and full knee replacements, you know.
Probably needs to get up-to-date x-rays or scans.
X-rays or MRI
what's going
scans.
on. Yeah,
absolutely.
exactly. Yeah. Gavin, thanks very much for joining us tonight.
Not at all.
There's
Thanks a million, Fiona.
questions?
I hope that the talk wasn't too over the top. As I say, I was trying to give information, but
Yeah.
perhaps a little too much sometimes. Thanks a million.
That's been great. Thank you. And just to
Bye-bye.
remind everybody as well that we'll be sending out an evaluation form. We really appreciate it if you fill it in, because we really take on board any comments you have or any recommendations for future talks. Thank you.